Good evening, friends. I am Dr. Srinivas Samavedam from Hyderabad. I am an intensivist and I have been the past Vice President of the Indian Society of Critical Care Medicine. Today I am here to muse and deliberate on an introspection I've had when I was thinking about where I have been and where I am today in the field of intensive care. And when I was thinking about it, I realized that I've completed more than 20 years in this dynamic field of intensive care medicine. While on that thought, I also realized that some of the practices which I learned as a student and probably would have taught my students in my initial days as a teacher have changed dramatically. And I thought I will probably in a sequential series of such introspection understand why these paradigms have shifted in the field of intensive care. Not only therapeutics, but the diagnostics, the organization of intensive care units, the availability of machinery, and the attitude of non-intensivists towards the field of intensive care have changed significantly, mostly for the better in the field of intensive care. If you look at what happened in 2002, 2003, when I began my career as a trainee in critical care at the Manipal Hospitals, Bangalore, and to what it is today, every unit today has advanced technology and they have access to state-of-the-art equipment which is available anywhere else in the world. That itself is a major paradigm shift. But I think the most important paradigm shift which I have noted and I realized has made a dramatic turnaround in the last 20 years is in the field of fluid therapy. Most of you probably would agree with me on that issue. Fluids have undergone several paradigm shifts in the last 20 years. The most important and the most long lasting and the far reaching paradigm shift is probably in the quantum of fluids which are being given to the patients. When I was a trainee in intensive care, people around me, my seniors probably, would be upset if I don't fill a patient to the gills with fluid if he had come with shock, especially septic shock. So the concept in 2002, 2003 was fill the patient, reassess, fill some more, and then you think about what you should do. You should start a vasopressor or what you should be doing. That paradigm has definitely changed to the point that intermittently in between in the 2012-2014 era, we thought we will go a little conservative when Manu Malbrain raised the point of the global interstitial perfusion syndrome. Now, after a plethora of studies which have shown that a positive fluid balance is definitely detrimental to a whole spectrum of patients, be it burns, be it traumatic brain injury, be it pancreatitis, be it ARDS, we now have gone into early conservative and late conservative strategy for fluid resuscitation for our patients with hemodynamic compromise. Probably what we also have to understand is that this paradigm shift has come not only because of the understanding of the detrimental effects of a positive fluid balance, but also we have tools at our disposal which can understand, which can tell us that we are overdoing our fluid resuscitation. I will dwell on this a little later in my discussion. Similarly, what has changed rather dramatically over the last 20 years or so is the type of fluids which are available to us. When I began my career in intensive care 20 years ago, the shelves in the emergency rooms, shelves in the ICUs and operating rooms were full of colloids and a mixture of colloids and crystalloids. And among the colloids, starches and gelatins were the predominant colloids which we used to have. And there were some units which were using aluminum even back then. And when a patient presents to us in shock and he's already been partially resuscitated elsewhere, the general thought process was to give colloids. And the colloids we used were gelatins in some units and some units use starches. I probably believe that starches continue to be used in some units, especially in the operating rooms, despite the evidence that acute kidney injury is probably more common among patients in shock who are resuscitated with starches. So from that era where we used to have gelatins in our ICU, we used to have dextrans in the ICU, we used to have starches in the ICU, we have slowly progressed to no starches, no dextrans, and no um, gelatins in the ICU for some time. So it was only saline, it was only lactated ringers or Hartmans as it is called in some parts of the world, and then that's about it until in 2015 and 16 there was this resurgence of so-called balanced crystalloids, and that became now an armamentarium. So the balanced crystalloids added to the pre-existent saline and lactated ringers on the shelves of the intensive care units. So that has been a paradigm shift, and initially there was a lot of enthusiasm that the balanced crystalloids could be the solution to the problems associated with overzealous and excessive administration of chloride containing fluid. Now, that realization has also been another paradigm shift. The importance of chloride first came up probably in 2005 and 2006 when the Stewart hypothesis crept into the mainstream of clinical assessment of blood gases of patients in the intensive care unit, and the detrimental effects of hyperchloremia probably came to the fore. That is when we understood that high chloride containing fluids in excessive amount are probably detrimental or probably harmful, and that set the scene and stage for the balanced crystalloids to come in. The initial enthusiasm of the balanced crystalloids, however, has not been matched by randomized controlled trials, and probably time will tell us whether the balanced crystalloids will score over the conventional chloride containing crystalloids and lactated ringers in the resuscitation of fluids. That's one paradigm, another paradigm shift which I have noted in my last 20 years. The most spectacular paradigm shift, I believe, is the demise of albumin. In 2004, the SAFE study was published, which actually shook the fundamentals of fluid resuscitation. It dispelled quite a few myths that crystalloids are inferior to colloids in the volume, and 1 of a colloid is equal to 3 of crystalloid. This basic myth was dispelled by the SAFE study. And the SAFE study, although done with 4% albumin, did not show any superiority of albumin over saline. So that actually brought the thought process of not using an expensive product, especially in low and middle income countries like ours, in the intensive care unit for resuscitation. Subsequently, several subsets of patients were evaluated, like traumatic brain injury and patients with burns, patients with pancreatitis, and no advantage was found. In fact, the oft quoted Albios study, which was supposed to argue in favor of albumin, did not actually include the traumatic brain injury cohort of patients in its database. So we don't yet know what is the effect of albumin, but we can definitely say that there is no advantage of using albumin over other fluids of resuscitation in patients with sepsis and septic shock. So that is another major paradigm shift. But one area where albumin continues to make news and continues to have a place for use in the intensive care unit is in the cirrhotic patients who need large volume paracentesis and probably fluid resuscitation. On these lines, again in 2005-2006, a single center, less than 100 patient study from Germany argued that if you give an albumin and diuretic infusion for patients with ARDS, you could get a better compliance and washout of carbon dioxide. This result has never been replicated in other studies. So even though some enthusiastic practitioners brought it to the bedside, it has not stood the test of time and has probably found its way out of the intensive care units. Now the third paradigm, or the fourth paradigm, which has shifted or which has changed in my view, in my perception, in my experience of 20 years, is the assessment of hypovolemia. The focus has shifted on identifying hypovolemia to identification of hypovolemia, but also identifying hypervolemia as well. That means while you use certain markers, while you use certain gadgets, you use certain tests to identify whether the patient is hypovolemic, you also have to understand and probably assess the patient that this is probably too much of fluid. I myself, in my 20 years of experience, have written two different articles on how much fluid is too much fluid. And every time I have written it, both articles written about 8 years apart, my understanding, my perspective, and my conclusions were diametrically opposite. That probably explains the difference in approaches 20 years ago to what we are doing at this point of time. We used central venous pressure. We used probably echocardiography even 20 years ago. But the central venous pressure again has undergone a little bit of paradigm shift. It was preferred, it was part of the reverse criteria, it reverse protocol. It became part of the Surviving Sepsis Campaign guidelines in 2004. But since then, the enthusiastic use of CVP has waned off, and its role as a predictor of preload or a right ventricular filling capacity has also decreased. But what CVP will probably come back as is a marker of your heart-lung interaction. Suppose your patient, if you are increasing the PEEP on a patient, your driving pressure is going up along with an increase in PEEP, it is probably a manifestation of RV dysfunction. So we are not looking at CVP as a marker of fluid adequacy or inadequacy. Probably it will come back into the intensive care units as a marker of heart-lung harmony or disharmony. Stroke volume variation was a very, very useful and very elegant method of identifying volume responsiveness or patients who are unresponsive to volume, and we spent a lot of energy in understanding the pros and cons, the caveats for using stroke volume variation, and for the best part of 10 years, maybe from 2007 or 2008 till 2019, stroke volume variation was and probably still is a reliable tool for assessing patients with who are hypovolemic, provided the tidal volumes, the heart rate, the spontaneous activity, they all fit into the caveats which we all know are included in the limitations of stroke volume variation. Somewhere along the line, around 2012 or 13, extravascular lung water came into the picture, and about 4 or 5 years, that actually drew a lot of attention, and a lot of advanced monitors with thermodilution technique came into the picture, and we were thinking that if you can actually measure the extravascular lung water, you would do a very scientific way, manage your patient's fluids in a very scientific way. Unfortunately, as with all other hemodynamic tools, it has also not translated into better clinical outcomes among critically ill patients, especially those with sepsis and septic shock. So now the focus has come to identify volume overload. Whether you use clinical assessment, whether you use bedside fluid chart measurement, you use echocardiography, you use lung ultrasound, or you use a combination of all this, avoiding fluid overload is probably the most important step which every intensivist who is doing fluid resuscitation has to bear in mind, and is probably a marker of quality among intensive care units. The fifth paradigm, which probably is again a major player, I can say an influencer, is the use of ultrasound. Way back in 2002 and 2003, when ultrasound first came into the intensive care units, and one of my teachers, the great Dr. Jose Chaco, insisted that every patient in the ICU should get an echocardiogram and should have assessment of right ventricular function. It was something that was drastic. We felt as students it was very drastic. Now it has become standard of care in most intensive care units. Now the advent of ultrasound has taken this whole paradigm of fluid management, assessment and optimization to a great new level. For quite some time, the IVC diameter, its collapsibility, its distensibility became the go-to tools to identify which patient could take more fluid, and more importantly, which patient cannot take more fluid. And that still probably is practiced in quite a number of majority of the units at this point of time. But once we have realized that positive fluid balance and fluid overload will kill as many patients as hypovolemia does, will produce acute kidney injury as much as hypovolemia does, the use of extended monitoring of vessels which are upstream or I can say downstream to the IVC has become an important aspect, and that is your hepatic vein, your portal vein, and your renal vein. So that's what I'm talking about is the vexus. So now the vexus is going to tell us that which patient is too full. He will tell us, the vexus will tell us who is not eligible for more fluid challenges, despite what the map, the vasexes, and other parameters are telling you. So the advent of ultrasound, the advent of training programs by societies like the ISCCM and other international critical care societies, and the enthusiasm of teachers of critical care in learning ultrasound and dissipating that knowledge to their students has probably brought about a very significant paradigm shift, which is probably going to influence the outcomes of quite a few patients in the intensive care unit. That I feel is a very good paradigm and a very positive paradigm shift in the field of fluid therapy in the last 20 years. We come back to chloride, right? When when people, when my colleagues or somebody used to talk about chloride in 2002, the chloride was looked upon as a joker, and they would say this is an inconsequential electrolyte. It is self-limiting; it will look after itself. From there, it came to the point that became a villain. Stewart hypothesis highlighted the fact that this is an essential aspect. The strong ion gap, the strong ion difference are all linked to chloride, and we were also probably caught up with the concept that hyperchloremic metabolic acidosis per se is an independent risk factor for acute kidney injury in the intensive care unit. But over the last 3-4 years, what we have understood that it is not the absolute number of chloride, but the quantum of fluid that carries that chloride that causes the damage to the kidneys. And the split trial clearly showed that while hyperchloremia is an essential factor, it does not actually alter the renal outcomes. So from a joker to a villain to a character artist, that's what I can see the progress of chloride in the last 20 years in the field of intensive care. One set of indices which have actually remained strong, have not shown any signs of wobbling under so much of pressure in the last 20 years are the dynamic indices. I mentioned about stroke volume variation. There is pulse pressure variation. There is end expiratory occlusion test, and quite proud to say our own contribution to this is the tidal volume challenge. And these dynamic indices have stood the test of time, and probably they are the paradigm shift which have moved over from a CVP, SCVO2 based therapy to a dynamic indices related fluid responsiveness or unresponsiveness coupled with a very effectively done sonographic indices. Another major paradigm that has not changed a lot is the mean arterial pressure. The concept of putting in arterial lines came in the year 2000-2001 into Indian intensive care units, and we now know that mean arterial pressure is probably the bare minimum which all of us should be doing to achieve good clinical outcomes. But what has happened is there has been a thought process that a higher MAP is, especially among hypertensive patients, is probably a better way or probably superior to the stat or the fixed 65 millimeters of mercury. But the recent randomized controlled trials which have compared 65, 75 and 85 MAP have shown that if you try to fill in patients with fluids and increase the dose of vasopressors to achieve a mean arterial pressure of more than 85, you stand a risk of triggering more arrhythmias. There are more ischemia related complications. There are more extravasation related complications, and the survival is not superior to those, and the vasopressor dose you use is much higher, and the survival is not superior to what you achieve by having a target of 65. There may be a small cohort of patients who benefit with a MAP of 75, but that has to be carefully individualized. So that brings us to the last aspect of paradigm shifts in intensive care, and that is personalized fluid therapy. So there are patients who need saline. There will be patients who will require balanced crystalloids. There will be patients who have a very disrupted glycocalyx where chloride can be more disruptive. And there will be patients like the cirrhotic patients who will still require albumin. So at this point of time, after 20 years of spending in the rough and tumble of intensive care, I can understand that there is no single fluid that is prescribed for all patients, and we need to be practical. Upgrading yourself with ultrasonography skills is probably the best way to do it, and always keep a combination of a sonographic parameter and a dynamic index in your armamentarium when you judge patients who need more fluid, or you need to identify patients who do not need more fluid. So friends, I think this has been my perception. I may have missed a few paradigm shifts, but I feel when I was thinking about what has happened in the last 20 years or so, I understand that there have been a lot of shifts, there have been a lot of changes, and what we insisted our students to learn in 2005, 2006 when I first became a teacher, to what I am teaching now in 2023 is totally different. And maybe I must say, I must apologize for the whole number of students for whom we insisted on them learning certain outdated principles. But those principles were current at that point of time. So that friends is the beauty of intensive care. What was hot 20 years ago is done and dusted and fossilized 20 years down the line. And this will keep happening, and my subsequent generations will again have this introspection about paradigm shifts in the field of intensive care. Thank you very much. Have a good day.